John,
Hey, Nick.
how are you, my friend?
I've been trying to get a hold of you.
You know that with Mario Ganao, we are very friends since many years.
Well, Facebook, I can't contact you. Can you give me a WhatsApp number?
I don't have. I
Hey.
told you. I told you that.
I've been trying to get a hold of you. Oh, you don't use WhatsApp?
No, I don't. For protection of my brain and
Okay.
protection of my marriage, I don't use WhatsApp.
Okay, how about use email, right?
Email and Zoom contact, such as now.
Okay, email's the best, right? I guess.
You are looking every year. You
Huh?
are like you are like the Greek god Zeus. You are looking younger every year, John.
I tell you, I can't wait to get back to Plaka.
Yes, we will invite you. Don't worry. In the
Oh yeah,
future, we
yeah.
will.
I'm gonna live in a little one-room apartment in Plaka
Okay,
with a
John.
computer and a big screen.
Okay, is it possible for me to try my slides? Can
Yeah,
you?
let's try it. Yeah, go ahead. We have time.
No, no. How? Share screen. Okay,
What you want to
share screen.
share your screen?
Uh,
You want to do a presentation? What do you want to do? You want to?
Yeah, I wanted to do my presentation.
Okay, go ahead. Try. Start.
I don't know where
Let's
the
practice. You want to
presentation.
practice? You want to practice?
Okay.
Do you want to practice?
Yes. No. 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 One moment only.
Okay, let's practice. Let's
Okay.
practice. There you go. That's it. Okay, yeah, that's good. Make the screen presentation mode.
Okay.
Do you know how to put presentation mode? At the very bottom, there's a couple of
Okay.
options.
Okay. Can you show my screen now? Yes.
Yeah, I can see your screen. Now look at the bottom of your screen. There's the three little
No.
icons. You must take one of those
Yes. No. No.
options.
No. You can see my presentation now. Yes.
Yeah, but it's not big. I can see what you see. You see it too, right?
No. No. My slides. Can you see it?
No. You need to put it on presentation mode. At the bottom, there's three icons.
I know. I know.
Okay, no, try it again. Okay, at the
Now.
bottom of the screen. No, at the bottom of the screen. You see the icons at the, no, at the bottom of the screen. Okay, let me take a picture. I will show you, okay? Hold on.
No. No. Now you can see my slides.
Have you ever done a presentation before?
Yes, I did many times.
Oh, okay, so what's the
Uh,
problem?
I don't know. I want to
Okay,
say
wait,
hello
let
also
me take it. Hold on.
to
Okay.
Dr. Mario Forcione. Hello, Mario.
Hello, hi,
Nice to
nice to
see
meet
you.
you. Hi, nice to see you too. Hi.
Okay.
I think the gentleman before was asking you to, there must be an icon. Unfortunately, everything is in Greek, so it's difficult to say, but
No,
No,
I'm
no, no,
gonna
no,
show,
no, no,
I'm
no,
gonna
no.
show him.
Mario, tutto in English. Everything is in English.
Yeah.
No,
What I meant was, yeah, of course, yeah. I meant the option on your page are in Greek, so I couldn't help you find the bottom that the gentleman
no, no,
before.
no, 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 no. I know. I did it also many times. I did
Okay.
share screen, but I don't know why he's not doing.
I see your point, of course.
Can you see it now?
Yeah, now it's fine. Now it's perfect.
You can see my presentation.
Yep.
Okay. John, we resolve it. Where is John?
Hold on,
John.
no, hold on.
Mario for John is able to see my presentation.
Yeah, I can. Yep.
Mario, where are you working?
So currently I'm in Milan, but I'm going to present my work done in the UK, in Birmingham.
Okay.
So I'm a registrar in Milan. Nice to meet you all.
Yes, okay. In Birmingham, there is some Greek guys like Chermoulas. You know Chermoulas and Zisakis, two Greeks.
I'm
No,
sorry,
no.
no, I don't. I'm sorry. Do you mind if I
You are
also try?
working.
Yep, go ahead. Sorry.
You are working in children hospital or in
No,
adults?
adult hospital. Yeah. Well, I spent right now I'm a registrar. I spent 6 months in Neuro ICU with Professor Citterio. You might heard about him.
Yes, I know him.
Yeah, so I was in his ward, and currently I'm in the general ITU. So I'm rotating from every 6 months. I'm rotating to a different ICU. I've been with I only did 3 months in pediatrics, but nothing serious. Everything was
It is
quite.
it is my friend Guri Solanki in the pediatric.
Okay, Nick. Okay, you see the screen? You see the screen now? You see the
Yes.
arrow? You see the arrow? Okay, there's 3 little icons at the bottom of the screen to make it
John, my friend,
present.
I know it very well. I know this thing. I adjust my buttons before, and Mario was able to see my presentation.
Okay, do you have it now? Okay, share screen now. Go ahead, try to share screen. I'll get off. Oh, that's good. That's good. You got it, Nick.
Oh,
Yeah,
okay,
you got
okay.
it. You got it.
No problem.
What are you
No
fooling
problem.
me for?
I don't know. The PC is like neurosurgery. You are never sure about the result.
Yeah, I run into all sort of language problems, and when someone's platforms in another language, oh, I'm lost. How do you?
May I also share my screen so I can be
Yeah,
sure
yeah.
to.
You go ahead. Go ahead.
Thank you, sir. Thank you. At the moment, I cannot share my screen.
Yeah,
Someone
sure.
has to enable.
Okay, Sam. Excuse me. Let me get my.
I left Dr. Mario, Dr. Forcioni. I left my share screen. Now you can share your presentation.
Oh, thank you, sir. Thank you. Appreciate it. You can call me Mario, by the way.
There you go.
Pleasure.
Mario, where you from?
So I'm from Italy, and
Okay.
I spent 6 months. Almost 6 years in the UK.
Oh, okay.
Yeah, so I'm going to present.
You don't have an accent.
Well, you're very kind to me, but yeah, I do have an accent, and I spoke with a very nice nurse who I called my English mother and said he's very good with girls, so I did my best to try to keep it.
Oh, okay.
So can you see my screen right now?
Yes. Okay. Well, do you want the next? Do you want it? Is that the way you want it to look? You have the next slide. Click to add notes. Do you want that part on, or do you
No,
want
no,
to?
no, no, not this one. Bear with me. I will
Yeah.
try
Just
to.
change the presentation to make it full screen.
Yeah, indeed. So yeah, now it should be this one. Share. How about now?
Now it's still the same. It's not full
Okay.
screen. It's not full
Yeah,
screen.
bear with me a second, sir.
Yeah.
So if I end the show a moment, And I
Yeah,
say
just
presenter view.
play with the, yeah, that's it. Try that.
Yeah, and now I should be able to share
Yeah, try it
only
again.
the PowerPoint. Yes.
Try it again.
No whiteboard, fixed person.
Nick,
just
while we're talking, oh, you can't put a post on Facebook. Okay.
Yes, about John, about this webinar. I posted many times.
Please put a post on Facebook.
Okay,
No,
okay. I will do it.
It's weird.
Okay.
So, but what if I do this way? So I think I have to run.
Go ahead, try it again.
Yeah, go ahead.
Just put the screen on and don't move it. I'll tell you where to go. Try it again.
Yeah.
And don't touch anything.
So if I just do play from start.
Take the screen.
Right. And yeah, now it should work.
Oh, perfect, perfect. Just
And
like that.
you can also see my pointer, right?
Yeah. Go ahead, move your pointer around. I can see it. Yep.
Okay.
You can actually make a better pointer if you go into the options. It'll make it a big arrow if you want. I certainly can see what you're doing now, but if you want to make a better pointer,
yeah, I can change the color.
You can play with that. You can make it a better pointer. Black, make it black, and
black. You think?
Make it a pen, whatever. Try something different. Or do you want to draw things? Maybe that would work.
I think I'm going to stick with the red one as it is. Yes,
that's fine. That's fine.
Yeah. The only problem is that I'm sorry that I cannot see the notes on the side of the screen, but I hope I did everything that I know how to do with PowerPoint, and I couldn't figure it out.
I don't know if you want to put the notes on the main screen, right? You don't want to do that, right?
Yeah, exactly. No, it's fine. I'm quite familiar with my presentation, so I should be able to work it out this way too. Yeah.
Yeah. Oh, good. Okay.
Really nice to meet you. You asked about me, but sorry, just because I was busy, I didn't have the time to ask about you, John. Where are you from, if I may?
Yeah, I'm from Florida, Miami, Florida.
I see. Nice to meet you.
Now, I grew up north, where it's cold, and now I'm here, and I don't want to leave the warm.
I see. My girlfriend is from Pennsylvania, but she lives in Ohio, so I'm planning to go there quite soon.
In Iowa?
In Ohio.
Ohio. Yeah. I did my internship there.
I see.
That's
Where about?
Middle of America, mid-America.
Yeah, indeed. I spent around 6 months in Illinois and more or less other 6 months in Ohio.
Yeah, that's the cold part of the country, in the Midwest.
Indeed.
Did you like the cold?
Well, yeah, I think because it's a different cold from the UK. You know, in the UK it's very humid too. There is a lot of moisture.
It's very difficult. Huh?
But in the US, I found it that is more, dry cold. So you tend to appreciate more. I mean, you do not suffer as much as in the UK because it's the humidity, bottom line, that it really affects you.
Yeah. It's I don't miss the cold. I've lived here too long, and now I suffer. When I go back, I suffer. I used to love it when I was growing up, but now it's like, oh, get me away, get me back to Florida.
I see. Nice. And are you also a neurosurgeon?
No, I was a regular doctor, ER doc. And I just went straight into computers. I mean, after I did like 15 years and that was it. So I started doing televising, and I liked it. I liked going all over the place and meeting people and arranging webinars. So yeah, it's going well. Nice. I may get a little televising a hand channel. HAND.
Okay.
Let me show you here.
Thank you, sir.
Yeah, sure. I'll show Nick too. Nick's an old friend.
So 20 minutes presentation. I prepare a presentation for
Yeah,
20 minutes.
yeah, okay. It's up to you, give or take. We're not really strict.
Okay, sounds good. Yeah, there are around 17 slides. I try to take my
Yeah,
time with each slide
That's
so that
fine.
not.
We're not real strict. Let me get to show you this. Okay, see the hand?
Uh-huh.
That's going to be another channel,
Interesting, yeah.
Hand TV. Because, you know, it's kind of mixed up. There's no really one central station because plastic surgeons do hand surgery, neurosurgeons do hand surgery, orthopedists do hand surgery, and they have regular specialist hand surgeon. So we're trying to make it in one place where they can all go, a central place for hand webinars.
I see.
So make me moderator. Okay, hold on.
Will it be recorded? Will the presentation be recorded?
Yes. Oh, you're here. Oh, Nargiza. You know Nargiza, the Uzbek.
No, I think I'm not familiar with.
The Uzbek fireball.
No.
Oh, there she is. Okay. There's Miriam. Okay, Mario.
Yes. Hello, everyone.
Hey, how you
Thank you, John.
doing?
I'm good. Thank you.
The Uzbek fireball. Do you mind if I call you a fireball?
I don't know. I don't think so.
Oh, it's a compliment. It's a compliment. You're
Thank
full of
you.
you're full of
If
energy.
it is,
Well, Mario, do you know Nargiza?
No. Hi, nice to meet you. I'm Mario. Hi, nice to meet you.
hello, sir.
She's the
Nice to
force
meet you.
behind this webcast. Hello,
guys.
Mario. How you doing, Mario?
I cannot hear anything.
You can't hear me?
Hmm.
Can you hear me now?
We can hear you, Mario. We are hearing you.
Yeah, we can hear you, Mario. You can't hear me? Okay, reboot. Can you hear me, Mario? Can you hear me?
I think he's not able to hear you. Okay, we will wait.
You may have to reboot, Mario, and come back in. Oh, maybe he is. Oh. Okay. He's not in, he may have stepped out.
Hello, everyone.
Hello, welcome.
Hello, Dr. Plum. Mhm.
Thank you. Thank you for inviting me.
Thank you, Dr. Bennett,
It's a great pleasure.
moderating. And Nicholas is over here meditating. Nicholas is another
Mhm.
speaker from Greece. Hello, Nick. Can you say a lot of Hui Pham, Dr. Pham? From Vietnam.
Hello,
Hello.
Vietnam,
Hello.
right? Right?
Yeah,
Yes, Vietnam.
Hanoi or Vietnam or
Yeah, I'm from Hanoi, the
Hanoi.
capital.
I heard it's a very nice city.
Yeah, you should go someday.
It looks beautiful. Looks beautiful. All of Vietnam, all of Vietnam.
Yeah.
Looks beautiful.
Hello, hi, nice to meet you. Hi,
Hello.
I'm Mario.
Okay, Mario, does your
We
computer
still
work?
have 4 minutes, so we will be waiting for Mario. I've texted
No,
him.
Mario's in.
Well, let's see
Mario,
what
can
he
you
says.
hear me?
Yeah, but maybe he has some, audio problems with connections or I don't
No,
know.
I haven't. He doesn't have a camera.
Mhm.
Mario, do you have a camera?
No, Mario has camera, but something we are not able to hear, or he is not able to hear us. Hmm.
Mario, your camera. Can you hear me, Mario? Your camera's not on. Neither is his. Your microphone is not on either, Mario. Do you have his WhatsApp,
Yeah, I
Narkisa?
have already texted him. I have asked, so
Yeah,
I'm waiting for his reply.
Yeah, he needs to. He was in, but he didn't have his
Mhm.
camera on.
Hmm. Okay, we will wait another 2 minutes, and
Okay.
since we are limited in time, we have just 1 hour,
Okay.
3 speakers, so we will start off, and
Okay, let's see
once
if Mario
Mario
can
get
get
the
in.
chance.
Let's see if Mario can
Yes,
get
yes.
in. Yeah, I understand that. We'll start with you, Nargisa. Mario, are you in yet?
Yes, can you hear me?
Yes, we can hear
Yes,
you.
we can hear you.
How about your camera?
Can you see me?
Not
No, we
yet.
can't.
You need to turn your camera on.
Can you see me?
Not yet.
No, not yet.
Yeah, I can see you.
Can you see me?
Yeah,
Now
I can see.
now
I
we
can
can.
see you, Mario, with one of the two links when you're connected.
Uh,
So Nargiza, is your time to shine, okay? You are moderating this.
okay. Now I can see you.
The
Okay,
format
let's.
then is up to you.
Yeah,
Mhm.
she's running the show basically. Okay,
Okay.
1 minute there, Nargisa. Okay. Okay, 3 presentations, right? About 20 minutes apiece.
Yes. So I'm starting. Should we
Yeah,
start
just in a second.
recording?
In a few minutes, I'll tell you.
Mhm.
Okay, okay, here we go. You ready?
Yes, we're ready.
Okay, 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning. This is Dr. John Bennett broadcasting from Miami Beach, home of Neurosurgical TV. We have today the Global Neurosurgical Grand Rounds from Oxford University. This webcast headed by Mario Ganau, and I'm going to have neurosurgeon introducer Nargiza Sartova, a neurosurgeon that is in India, and she'll be basically moderating. Welcome, Nargiza.
Hello, John. Hello, everyone. It's a great pleasure to moderate this new type of our grand rounds, global neurosurgical grand rounds today. And today we will be talking about traumatic brain injury. As I said on my previous presentations, no matter how we are succeed in any branch of neurosurgical field, traumatic brain injury is and will still have the biggest amount of patients in all hospitals in all countries. And this topic will be remaining the most actual topics of all neurosurgical topics ever. And today I would like to present and to introduce our first speaker from Vietnam, Hanoi, Huy Pham, MD. He's from Viet Duc University Hospital of Hanoi, Vietnam, and Dr. Huy will be talking about cerebrospinal fluid leak following traumatic brain injury, diagnosis and treatment. Thank you.
Okay, start sharing now.
Yes.
Yes, please share it. You can share your screen. Yes, we can see your screen. Thank you.
Okay. Thank you for having me. My name is Huy Pham. I'm from Viet Duc University Hospital in the capital of Hanoi, Vietnam. I'm going to present to you my topic, cerebrospinal fluid leak following traumatic brain injury, diagnosis and treatment. So I will begin with the epidemiology. CSF leak is found in 1 to 3% of all blood TBI patient, adult patient, and 10 to 30% of the skull-based fractures. 80 to 90% of the causes of CSF leak in adult patient are due to head injury. Over half of the CSF leaks is presented within 48 hours, but some other cases might present later, but mostly within 3 months from the time of injury. Regarding the pathophysiologies, the CSF leak is nearly always associated with cranial fracture, especially the skull-based fracture. The most common fracture sites are the frontal sinus, sphenoid sinus, ethmoid sinus. So they are mostly in the anterior cranial base. The body defect size, degree of dural disruption, arachnoid tearing, and ICP are the factors that primarily influence the formation of CSF rhinorrhea. The anterior cranial fossa fractures are more prone to CSF leak than middle fossa fractures. And the reason might be related to the tighter adherence of dura to the cranial base bone than the middle fossa. And also the anterior cranial bone is thinner than the middle fossa. So it might have developed more bony defects than the middle fossa. The time of CSF leak is very important because it affects the long-term prognosis and also the associated complications, especially meningitis. The early onset is defined within 48 hours from the trauma time. And in most cases of blunt injury, CSF rhinorrhea usually begins within 48 hours. And if the fracture is not last, most of the cases will heal naturally. And the delay onset is defined that at least 1 week after trauma, and there are some reasons for delay onset. That might be because of the blood clot disappears that open the dura and skull defects for the CSF to going out. the separation of dura and arachnoid caused by the decrease of cerebral edema after injury and after treatment. And also growing skull fractures as well that might be seen more often in children. And for the clinical presentation, beside the trauma symptom, the patient have the CSF leaks usually presented with rhinorrhea or autouria, and the fluid is usually clear and watery and positional dependent. The reservoir size, the CSF leak that occur when the head is up from the lying position. For the metatarsal fracture, the patient might develop ear fullness and hearing loss. And if the fluid leak collected within the tympanic cavity depends on the tympanic membrane. If it's intact, it might flow to the eustachian tube and patient develop rhinorrhea. But on the other hand, if the tympanic membrane is disrupted, autouria might develop. Some patients also present with recurrent meningitis or cerebral abscess as a complication of CSF leak. One of the main questions in clinical diagnosis is that really the CSF or other fluids, particularly nasal secretory or inflammatory? So there are the difference of diagnosis on clinical setting. The tachycardia might be clinically efficient to differentiate. There are two rings on filter paper for CSF, the inner ring that circulate the blood inside, while the outer ring that circulate the CSF. Handkerchief test that differentiate the CSF and the nasal discharge or nasal inflammatory fluid by the sticky characteristic. The CSF is not sticky on it. We can also use some other tests with bedside glucose oxidase assay. We can measure the glucose and protein concentration and compare between the two. But the gold standard to confirm the CSF is the beta-2 transferrin test. Beta-2 transferrin is produced by neuraminidase activity from many in the CSF. It has a very high sensitivity and specificity. But the problem is that this study is relatively expensive and also time-consuming. We have the alternative. That is the beta-chase protein. That is the second most common protein in the cerebrospinal fluid after albumin, and is produced mainly by epithelial cells lighting the left meninges and choroid plexus. This test is much cheaper than the upper one and also less time consuming. So it might be a good candidate, again, alternative to beta-2 transferrin test. Imaging investigation with different modalities are important in identifying the leaking point and making decision for definitive management. CT scan is important to identify and evaluate the bony fractures and pneumocephalus that you can see on this scan. CT cysternography is more invasive, but it also might have influence as well. You can see here, this is a leaking point at the ethmoid sinus on the right side. MRIs, within the MRI, CSF is observed as a high signal intensity on T2 images, while the perimucosal discharge is seen in low signal intensity, so we can differentiate between the two. The leak point we can identify, and also we can diagnose the brain herniation through the bony defects in some cases as well. MRI with intrathecal contrast or cysternography might be less widely used. The other test is chase test that we can inject the fluorescent intrathecally, and 1 or 2 hours after the injection, we can use endoscopic investigation to see if there is a leak. Management, there are two main options that you already know: conservative and surgery. Treatment option selection depends primarily on the cause of leg, the size of leg, the timing of leg, and associated injury, brain herniation, meningitis, for example. Conservative management should be considered as first line in most cases, and effective in most cases. It includes head elevation to around 30 to 45 degrees. The patient should be at bed rest and avoid the activity that increase ICP, like coughing, straining, retching. We can have some CSF diversion, mostly lumbar drainage with a rate of about 10 to 50 millimeter per hour. We rarely use ventricular drainage because I think it's more risky, especially for meningitis. Caution during the conservative treatment should be taken for meningitis. Management of meningitis, meningitis is observed in 19% of persistent CSF leg with 10% of mortality reported by some papers. And the delayed CSF leakage and the longer duration of the leakage, we can concomitant infection have higher risk of meningitis. The most commonly found agents are streptococcus pneumonia and Haemophilus influenza. There's a controversy in the prophylactic antibiotics for meningitis after CSF leg. But there is a systematic review on Cochrane that found no difference between the use and not use of prophylactic antibiotics for meningitis. If used, ceftriaxone is usually used along with ampicillin and sulfadiazine. Surgery is indicated early for penetrating injury for the patient present with meningitis, with large intracranial hemorrhage cell, with the herniation of the brain tissue through the nose and ear. Surgery should be considered if the conservative management fail. They are defined as persistent CSF leakage, recurrence on delayed CSF leakage, recurrent pneumocephalus. The time to assess the success or the failure of conservative management vary a little between different institutions and different doctors by experience. But in my place, we usually define that after 7 days of conservative management. To fix the CSF leg, I define that into the location of the skull base fracture by anterior and middle and posterior skull base fracture. For anterior skull base fracture, we can do that extracranially or intracranially. Extracranially, mostly endoscopic endonasal is now the first choice in most cases. It has low risk of retraction injury to the brain cortex and olfactive function. It can have access sphenoid paracellular and posterior ethmoid region conveniently. The success rate is reported to be very high, over 90%, and also low rate of complications. It also has very good cosmetic results as well. Transfacial approach that was used in some cases, but now is rarely employed. Intracranial approach also can be considered to be classical. It has advantages of offering a wide operation field, and along with that CSF fixation, we can do the other surgical purposes as well, cranioplasty, for example. And it could be used for the patient with large skull base defect with craniofacial reconstruction required. For the intracranial approaches, that could be intradural or extradural. The main factor to choose intradural or extradural is the olfactive function. if the olfactory function is intact, the intradural approach should be used, but caution should be taken to avoid contusion, hematoma, edema to the brain. For the extradural approach that could be used for anosmic patients, we can place some split graft to repair the bony defects. With the middle and posterior cranial fossa, the middle fossa approach could CSF leg could be fixed intradurally or extradurally, but the risk of labia and risk of fixed nerve respectively should be considered. We can sometimes use endoscopic by transmastoid and transnasal approach, but this is that I see only on the literature. I have never seen that in real life practice. And the posterior fossa fracture rarely requires repair. Surgery might be needed in the cases that the fracture that is done to the middle fossa. The one of the main challenges that we found during surgery is where the leakage point is. In some cases that we can find out by the point that the watery fluid going out through the dural defect. But in some cases that might be difficult. So we can use intrathecal non-radioactive substances or fluorescence or cotton plat that apply adjacent to the site of suspected fracture. And if it's a CSF, that will show the green discoloration of yellow fluorescent dye. Navigation system also helps as well if we can find the leaking point preoperatively. There are different types of graft for fistula repair because the CSF leak is mostly repaired by closing the fistula with graft material, and that might be autograft, allograft, or xenograft. For the autograft, for the intradural approach, I prefer the pericranium. And for the endoscopic, I mostly use the septal flap. I also harvest the fat from the abdomen in some cases as well to enforce the fixation. We can also use the other material that are allograft like gelatin response, Surgisan, fibrin. For the cranioplasty, we can use titanium mask, PPR, salmons. So this is the one of the cases that are operated in my institution. It was a 41-year-old male patient. He suffered from traffic accident. He was treated conservatively in the hospital, but 1 month after the trauma, he developed rhinorrhea, and on the CT scan here, you can see the fracture of the ethmoid sinus and the collection of the CSF within the sinus. And after 1 week of conservative treatment with lumbar drain, we proceed that failed, and we proceeded to adonasal endoscopic repair. So this is the video of the surgery. We go mononostrally on the right side, and we cut the middle terminus, upper terminus as well. Identify the leaking point. In this case, that we've found that easily the leaking point as the CSF flowing apparently. And then we harvested the septum flap on the right side to cover the defects afterwards. But before that, I also placed some fat that I harvested from the abdomen to the leaking point. I placed different layers of fat, surgisan, and finally placed some the septum flap on it. In summary, post-traumatic CSF leaks are uncommon and usually combined with spontaneous healing. Differentiating with other conditions might be challenging. Clinical, biochemical, and radiological study are needed to accurately diagnose and aid the treatment of this condition. Post-traumatic CSF leak can be treated either conservatively or surgically. Surgical obliteration of the CSF leaks can be performed intracranially and endoscopically. The other references that worth reading, and I use a lot in my presentation. Thank you very much for your attention.
Thank you, Dr. Pam, for your great presentation. It was interesting, and we will keep questions and discussions after all speakers are done. Let me move to our second speaker, Dr. Mario Farcioni, MD, PhD from University of Birmingham, United Kingdom, and Dr. Mario will be talking about contrast enhanced diffuse optical tomography in acute, moderate, and severe traumatic brain injury. Thank you.
Hello. Hello, hi.
Hello.
Pleasure for me
Yes.
being here. So currently I'm a registrar in the University of Milan in Italy, but I'm still conducting my research work in the University of Birmingham. So my subspecialty is brain trauma, and especially the ICU care using NIRS. So what's NIRS? NIRS is an imaging technique which is based on the absorption and scattering of light within the near-infrared spectrum across the biological tissue, in this case, across the brain. As you can see in this picture, it involves mainly the superficial part of the brain, so it doesn't go deeper, much deeper than the neocortex, usually. And clinicians are mainly familiar with this type of NIRS, where you can do a spectroscopy of the oxy and deoxyhemoglobin components within the volume illuminated. But there are multiple types of NIRS, so you can see that adding new channels, you can have a clearer image, and you can also add a topography image on a tomography if you could register the signal into into a structural imaging. If you include many channels into a structural imaging, you have what is called high density diffuse optical tomography. By doing so, you can enhance the quality of the optical resolution from a spatial resolution far lower than MRI into one similar to the MRI. But diffuse optical tomography is extremely powerful in brain trauma, not only for the optical signal itself, but also because it will give you a more precise assessment of what's going on a patient which is recovering in the ICU after brain trauma. In this review, we analyze all the possible components that may affect tissue respiration in a brain trauma care, and we try to list all possible tools that we can use as clinicians in order to evaluate the brain status. Diffuse optical tomography in particular can be also increased with using contrast enhanced diffuse optical tomography. So I also include the passage of a dye. And by adding the structural image of that patient on the optical image that I acquired, I can address different problems that we try to discuss in this review. For example, here we can see an epidural hematoma that completely completely absorbs the signal, and so it does not allow to the NIRS technique to go deeper into assessment of the parenchyma. Similarly, the subarachnoid hemorrhage might have an impact on the optical signal itself, and obviously brain cerebral hemorrhage. After the compressive craniectomy, after the point of evacuation of the epidural hematoma, these elements will be eliminated, so that the optical signal acquired from point A to point B might be changed simply because of what we did, not because of what has been changed in the parenchyma we scan. By adding contrast enhanced diffuse optical tomography, so we can better assess the brain status of the patient. In particular, the kinetic of the dye and the difference kinetic between the intracranial and extracranial tissue might be key to properly assess what's the perfusion in that brain. So, for example, here we have a very high level of perfusion in a normal brain, much higher than the perfusion which is in the extracranial tissue, which obviously is also illuminated when apply probes on the scalp. This difference in perfusion and this difference in washout, the washout also is very much quicker in the intracranial tissue than the extracranial tissue, will be eliminated if I have brain trauma, so a reduction on perfusion. And so obviously also the washout, so the tissue inflow will be approximately the same. During the end of the curve of an ICG, after an ICG injection, we can also assess how is the blood-brain barrier damage by assessing the leakage of the ICG into the parenchyma. So these two parameters, perfusion and blood-brain barrier damage, can be inferred to a certain extent by adding an indocyanine green to our contrast-enhanced diffuse optical tomography. The comparison between intracranial tissue and extracranial tissue can be even more important in a trauma patients where we do not only have brain trauma on its own, but sometimes, although epidemiologically it's reducing its number, but sometimes we might have many other injuries, systemic injuries that might affect the shape of a contrast dye. Starting with where we are going to inject the dye. So obviously we have a peripheral cannula, a central cannula here from a jugular vein, from femoral vein. All these elements will affect the shape of the curve that we assess on the brain. The level of volemia. So obviously here we have much lower perfusion than after replenishment, as obviously has happened often with hemorrhagic, after brain trauma who have suffered from hemorrhage. The shape of the lung perfusion itself might shape the curve as we assess on the brain. So obviously in this right lung, we have a higher compliance than in the left one, so that our pressure that is in ventilation will be mainly affecting with an over distension the right lung rather than the left lung. This will not be true after a while, where we remove the pneumothorax, we reduce the fracture on the ribs, we reduce the number of lung contusion, etc., etc. So all these elements might fool us in a better perfusion to the brain, while in reality it's a better systemic perfusion. So in all the components, all the organs aside from the brain. The analysis, the comparison between intracranial and extracranial tissue might solve, to a certain extent, this issue by simply comparing two elements that are both perfused approximately at the same. So these were my sort of what is the status of application of DOT in brain trauma. Here I'm going to present what is our work in order to enhance this care using NIRS. So our first step was trying to find a way to apply DOT, diffuse optical tomography, in a setting like the ICU. No one did it before. We are the first one to present that. So we took one helmet, optical helmet, as is currently used especially for neurocognitive tasks, and we tried to adapt it so that we could address all the issues that we might find in ICU patients, allowing us to do a multi-monitor monitoring. So we pay attention to keep the Coker's point free. We try to shield the probes from the ambient light that might affect the signal. And we use a reference point that I'm going to explain in a second on the helmet, so that we can try to co-register the signal on the patient structural imaging, so that all the problems I mentioned earlier on could be addressed. Our first task was trying to test the accuracy of the model that we applied to do co-registration, and the accuracy of the optical signal as acquired. And we use healthy volunteers in order to do that. The first task was trying to compare a method that is based on a 3D printer scanning using fiducial points, compare with an electromagnetic digitization that obviously isn't applicable in ICU because there is magnet all over the places in an ICU bed. But we can do a 3D scan of these patients. So how accurate is the two co-registrations? And the second one is how accurate we are in measuring the ICT, the intracranial tissue, and how accurate we are in comparing the ICT and the ECT, so intracranial and extracranial tissues. And we did so in 23 volunteers. In these volunteers, we try to do the co-registration part that I'm going to show you in a second, and also the Valsalva maneuver. The Valsalva maneuver is a physiological maneuver where you basically have an expiration with closed glottis, and that gives you a first high level of inflow to the brain. But then, because of the reduction of the venous return, you have a very low cardiac output. So the metabolism in the brain will lead to a reduction of saturation. This will not be true for the extracanal tissue, which obviously doesn't have the same metabolism that is in the brain, so that we can properly split the two signals. It's quite a powerful maneuver. So here are the results for the co-registration part. You can appreciate that we have a difference between the electromagnetic digitization and the one based on these fiducial points that we simply do with a 3D printer scanner of half of a centimeter approximately, which is quite very good analysis as a first step, definitely as a first step. More interesting, we said that at the beginning we did a lot of fiducial points, but we figured out that after 10, more or less you plateau the curve, so you don't get much higher accuracy, even increasing the number, which obviously will lead to even quicker assessment. Here are the results related to the healthy volunteers part. So we co-registered the probes on a template for what concerned the healthy volunteers. And we did what is called finite element model reconstruction. So we analyzed how deeper was the signal, what is the illuminated volume that we did. As I mentioned before, the optical technique pertains especially the superficial part of the brain. And then we separated the two layers, intracranial and extracranial tissue. This was possible because we did DOT, so we were absolutely certain about the depth of each layer. And you can appreciate that during the resting state, the intracranial and extracranial tissue saturation do not change very much. But this is not true about them for when we have the Valsalva maneuver. When we have the Valsalva maneuver, you can properly appreciate that, wow, the extracranial tissue goes up as expected, saturation, and the intracranial tissue progressively desaturate. So this capacity to properly split the two signals and at the same time to properly isolate the intracranial and extracranial tissue might be the key also to analyze the contrast dye passage, so that we can properly infer the perfusion and the blood-brain barrier damage. And this is exactly what was the next step. So we use approximately the same method of co-registration, so that with a 3D scanner, we could register the patient. And then we did the optical analysis. The optical analysis was done injecting 5 milliliters with a concentration of 1 milligram per milliliter of ICG. We injected 2 boluses, and which shows that the signal was smoother. We start to record for 10 minutes after the injection. We did 2 minutes of baseline just to make sure that the signal was absolutely on the baseline. Here is the process of co-registration as is designed by us 1 day before, so it's absolutely obviously open to reviewed, but it's quite novel on its own. And so from the 3D scanner, we just measure the fiducial points of measure and the point of reference, and then we co-register these points on the patient CT scan, which obviously the patient did it on for his diagnostic process. Here are the results. So here are the proposition on the patient CT scan. Here is the finite element model reconstruction on the patient CT scan, which obviously might change according to different where the lesions are and what kind of lesions there are. Here is the description of the source detector distances, which obviously affect the depth of the signal. So obviously between 20 and 30 millimeters was the majority of our channel distance. And here is the results related to the passage of the dye. You can appreciate how we separate the intracranial and extracranial tissue. And here is the inflow of the curves. Related to the 690 nanometers, that was not really significant, but this is an agreement with the optical properties of the ICG, which is not really detected with 690. But with 830 nanometers, you can properly see a very nice smooth, which obviously is the cinetic of the dye. Out of this curve, we feel, of our analysis, that the width of the curve in the full width maximum might be the key to properly measure the perfusion, because obviously the lower is the perfusion and the lower is the outflow, the longer it takes to the dye to properly pass through the brain. So obviously that will affect the length of the curve. We did an analysis comparing the width of the curve on the right hemisphere compared with the analysis done by a neurosurgeon, who by looking the simple CT scans tried to infer what will be the grade of perfusion. So if he considered that the left hemisphere was much more severely affected than the right, we grade it as -1. If it was more in the right than the left, we grade it as 1. 0.5 will be in the middle, and 0 if there is no difference in perfusion between hemispheres. It doesn't matter if he was severely affected by contusion, edema, etc., but if there was no significant difference on his eyes by looking in the CT scan. And you can see that the regression is absolutely confirmed between the results that we obtain using the full width maximum and what he thought will be seen. Here you should note that we use the ratio between brain and scalp so that we can rule out all the problems that I mentioned earlier on related to systemic influences to the ICG signal. For the left here and for the here, you can properly see p-values that absolutely are as expected. Just to be sure that the previous graph was accurate, we want to make sure that that was not related because of the scalp changes, so but only because of the ICT signal, so the brain signal. And while you can see that the linear regression is okay related to the brain and obviously is as expected for the left and right hemisphere with -1 and +1 as expected by the neurosurgeon, this is not true for the scalp. So by saying so, we can say that the signal, yes, indeed, was because of the brain, not because of the scalp. I would like to conclude my presentation not with the bullet points, but with a picture. This is hopefully the future, how I envision the brain trauma care in the future. So something that we add to the clinicians in charge of a patient, not simply the structural image of a patient, but also how is the perfusion of this patient, how is the perfusion over time. So you can have a proper monitoring during time, you can the level of your target of ICP, your target of mean arterial blood pressure, etc., also in agreement with the contrast enhanced diffuse optical tomography. I feel this will be the image that hopefully one day will be accessible to every clinician. I would like to particularly mention Professor Belli, who is my principal investigator in the University of Birmingham, and Professor Chiarelli from Chieti Pescara, who did the majority of the data analysis that I presented today. Thank you.
Thank you so much, Dr. Mario, for your presentation. It's something new. I haven't heard it before, and I will definitely go for literature. Thank you so much. Let's go for our third speaker, and after that, we will start our discussion. Let me introduce Dr. Nikolaos Sirmos, MD, PhD from Aristotle University, Thessaloniki, Greece. Dr. Nikolaos will be talking about current trends in management of sport-related traumatic brain injury. Thank you. Dr. Nikolaos, you can share your screen.
Hello, everybody.
Hello.
One moment only. I have a technical issue.
Excuse me, Nick, your screen is really dark. Can we get some light in
Maybe
there?
Sir will share the screen and then we will see, because it's just a video.
You need to change the light in your room. Go ahead, Nick. Maybe open the window or curtain. Go ahead, Nick. Can we lose you?
Yes, sir. Now
No.
I'm
here.
Oh, there you go. It's perfect now. It's okay. It's okay.
Oh, perfect. Yes.
All set, Nick?
Yes, you can share your screen.
How you doing, Nick? Did we lose you?
Dr. Nikolaos,
No,
is
I'm
everything
here.
okay?
I'm here.
Are-
I'm here, John. Just give me 5 seconds.
Okay. By the time we can discuss, if anybody has any comments or maybe questions to our previous two speakers. I would like to, sorry, I didn't introduce before, to talk about Dr. Mario Ganao, MD PhD from University of Oxford. Dr. Mario is the one who restarted our global neurosurgical grand rounds and keep helping
Okay,
all
next
of us
working
and young
on,
neurosurgeons. So,
So Nick, are you ready?
May I? Yes, may I start?
Please
yeah,
go ahead.
perfect,
Yes.
perfect.
yes, please.
Okay, good evening, everybody from Thessaloniki, Greece. I'm Nikolaos Chirmos. I'm consultant neurosurgeon. I really appreciate this invitation by Dr. Ganao and Dr. Satova, and also our friend John Bennett, that she's the main host here, a Zoom host, a global Zoom host. I will speak about the management of sports related traumatic brain injury. It's a great topic. I'm also a neurosurgeon and both a sports physician. And I'm currently working in order to manage to edit some guidelines also in Greek language about the management of these events. When we are speaking about traumatic brain injury in sports, we are speaking about concussions. It is the most common type. And the importance of this study is that this traumatic situation interferes negatively the most times with the normal function of the brains. The understanding of the sports-related concussion and the sport traumatic brain injury has evolved in recent years. And now we know that all the athletes, both amateur athletes and both professional athletes, are particularly vulnerable in the effects of the traumatic brain injury. Sometimes we can also have deaths in these situations, but most of the time we have multi-traumatic brain injuries and sometimes severe. The problem is very, very big and very ancient through the ages. Who does not know the past and who does not respect the present has no future. If you go to the beautiful islands of Santorini, you can see the Akrotiri boxer fresco discovered in 1967. And we can see the wall paintings of Tira, and we saw the boxers of Santorini. Look how marvelous is this painting. We can also see the hair, the box, and the movements of the body of these young boxers of Santorini. This is to realize, and this is also a result of how important is the traumatic brain injuries through the ages in all the people and all the civilities of the ancient and also of the modern world. When we can move also in Scottish Premier League, we can show the traumatic brain injury that caused the death of this young goalkeeper, Portiero, like the Italian. They said it was a match between Celtic and Rangers, and this is a traumatic brain injury that caused the death of this young boy around 100 years before or more. Many things we learn about the traumatic brain injury from Sid Watkins. It was the neurosurgeon, it was the capital medical officer of the Formula One for almost 20 years. Sid Watkins, a British neurosurgeon. And we learn many things from his achievements and his books and his speak about how to manage traumatic brain injury in sport. What is a concussion? A concussion is a very huge terminology. It's a huge terminology. It's minor brain injury, but sometimes we can also have a serious problem. Concussion is defined as a traumatically induced patient disturbance of brain function and involves a complex pathophysiological process. Concussion is a subset of a mild traumatic injury, which generally is self-limited and the less severe end of the brain injury spectrum, and we don't have never forget these things. These three designs is from Caligaris. Caligaris was a sports medicine physician from North Italy, also a friend and teacher of mine, who gives the mechanism of traumatic brain injuries in football, soccer, but also in the sports athletic activity that involves teams. Teams contact sports such as football, soccer, basketball, handball, volleyball, and many others. This percentage from USA female soccer, we can show that head-to-head is the most common type and the most common mechanism of provoking a traumatic brain injury. Compact sports are very popular, and it is a major cause of traumatic brain injury. And also contact and compact sports, we can see also this. Because we are living in difficult times, and we can also see violence in sports. And sometimes violence in sports can also product us a traumatic brain injury. The pathophysiology is very important, and it is the common pathophysiology of the traumatic brain injury. We do not have to forget that it's a very complex injury, the traumatic brain injury. It affects both the structure and both the function of the brain. The sudden movements can provoke lesions also in brain parenchyma, but also in the cervical spine, and we do not have to forget this. The diagnosis, it is with the clinical exam, the X-ray exam, the CT exam, and the MRI exam, as all of us we know that. The recognition and the management, it is very important, and it is very important when our people and our patients are elements that they are participating in sports activity. The symptoms reported by athletes, it's a very huge rate of symptoms, from headache, nausea, and also memory problems, sluggish problems, and it is a huge rate of symptoms. The important note is that as sports physicians and as neurosurgeons, we have to be able to diagnose a concussion. This is we don't have not to forget. And there are some signs observed by parents, friends, teachers, or coaches that they are the red flags that we can lead us in order to diagnose the concussion. The four-step action is this important: remove the athlete from play when we are sure that we have a concussion. Ensure that the athlete is evaluated by appropriate healthcare professional. Inform the athlete, parents, and guardians about the possible concussion, and keep out the athlete out of play the day of the injury and perhaps sometimes after the injury. The signs and the symptoms are the primitive signs of behaviors that they can affect also the sports life and also the normal life of the athletes. We do not have never forget that when we are dealing about sports and sportsman and sportswoman, we are dealing also about people that they have also their normal life. The repeat concussion, it is the traumatic brain injury. After the traumatic brain injury, we have many examples in compact and contact sports. And very important is how to manage, how to be able to evaluate a cognitive rest about a cognitive correct rest about our patients and our athletes. It's very, very important. Important also is this RTP, return to play. No athlete should return to play or practice on the same day after a concussion. Okay. Athletes were allowed to return previously to play. Their symptoms resolved within 15 minutes of the injury, but the newer studies they avoid these things. We have to be sure that the patients can return to play and the patients, the athletes are safe. This is the main gold standard, the PPAP, the Progressive Physical Activity Problems. It has 5 steps. Light aerobic exercise, moderate aerobic exercise, no contact training deals in full uniform, full contact practice, and full gameplay. This is the rules, but we can moderate these rules when we have some sports. This is the moderation according to the sports activity. We do not have a night to forget. This is the International Conference of Concussion. It is a periodically conference. The last time we were in Amsterdam. And this is the rehabilitation stage from no activity, light aerobic exercise, sport-specific exercise, no contact training deals, and full contact practice. And the 6th day is the return to play. It is very, very big question. What to do in emergency? Evaluate the patient correct, evaluate the athlete correct, evaluate the amateur athlete correct, and evaluate the professional athlete correct. When we are dealing with professional athletes, there are also economic issues beside them, contracts, sponsors, teams, and we have to be very, very, very carefully evaluation when we have to do with professional sports. Soccer is one of the major and one is the king of the sports worldwide. The ball sometimes affects and provocates also traumatic brain injury. And the suggested concussion management, it is up to the medical clearance, return to play rules, and return to play based upon a return of any signs or symptoms. This is a very important thing. And the important thing is the appropriate healthcare professional management. It is very, very important, essential in order to have a good management. This is the symptoms, the signs, the sequelae temporal, the age, the medication, and the behavior in sports according to the time and the sports activity. There are also many publications and there are useful tools. The management of the concussion in athletics, it is an area of sports medicine that continually evolves. Several methods of evaluating and management concussion that were once considered standards of care are now obsolete. The importance of providing correct clinical decision for the assessment management and return to play criteria in people, sportsmen and sportswomen who have sustained concussions remains one of the greatest challenges to sports medicine providers. This is some things about prevention. You know, this strip around the head. It is in USA female soccer. This is the ECOSEP, European College of Sport Physicians. This is the Sports on Field Trauma Emergency Course. The SCAT, a sports concussion assessment tool provided by FIFA, also an important tool about evaluating the sport concussion. They has some curricula in order to perform these things. And if no doubt, let them out. This is the British concussion guidelines edited in April 2023 about the sports. And also our British friends provide the 6 steps in order to return to play, as we said before. I'm really grateful and really honored to be here with us, my dearest friend. And I want to dedicate this short presentation to my friend and my teacher, Sandeep Chatterjee, a pediatric neurosurgeon from Western India, that we lost him some months ago. She will be missed to us, but we will never forget him. Thank you very much, and I think that I keep the time.
Thank you, Nikolaos. Very good
Thank you so
presentation.
much.
I think we're done for the day. Shall we start the Q&A session? Nargiza, are you happy?
Yes, thank you, Dr. Nikolaos, for the great presentation. Yes, we can start the discussion and questions if anyone has questions. Dr. Mario, maybe you will give
Yeah,
some
can
comments.
I start with the presentation from Dr. Pham? So can I just ask, in terms of the conservative management, you mentioned either EVD or lumbar drain, obviously with lumbar drain being favored because it's least invasive. But for how long can we consider conservative management before deeming that the patient requires an escalation of treatment?
Thank you for the question, Dr. Mario. Lumbar drain is usually incorporated in the conservative management from the first day after diagnosis, and the time to assess the success or failure of conservative management yeah, in my place, in my institution, is a week, is 7 days. But I know some doctors may extend the assessing time into up to 10 days. But as my experience, usually the effects of lumbar drain can, if it's really effective to treat this septic, we can see a result very soon after implementation. And also, we also use the lumbar drain after surgeries as well. We keep that for around 3 to 5 days, and then we close the drain, but we still keep that on the patient to evaluate if there is a leak through the symptom of rhinorrhea or arterial afterwards.
Sure. And in terms of your personal experience, what is your failure rate for the endoscopic reconstruction?
This success rate in some reports are around 90%, and even some study they reported 98% in for the first attempt of endoscopic endonasal fixation.
So am I right in drawing as a take-home message that unless patient requires an intracranial approach, the endoscopic should always be the first step after a lumbar drain?
Yeah, I totally agree with that.
Yeah. I think you framed this take-home message very well in the presentation. I want to congratulate you. It was a very nice talk and with a nice exemplified case. And for me personally, it was a pleasure to have colleagues from Vietnam participating in our grand rounds. This was a first, but I hope that you will be able to join us even in the future.
Thank you for giving me this opportunity, and I'm willing to participate as a speaker or attendees in the future webinars.
Thank you. It will be our pleasure. Nagiza, do you have any question for Hui, or shall we move directly to Dr. Forcione?
No, I don't have questions. We can move for our second speaker if you have questions, because I have questions to Dr. Nikolaos.
Okay. Mario, can I ask you a few questions?
Please, yes, of course.
So first of all, for those who are not aware, Mario and I, we have worked together in Birmingham and also collaborated on scientific matters. We actually authored one of the paper that he showed in his presentation. And I think I'm conveying them, a very strong message when I say you have been a super clear speaker. You really made sure that anyone, even those that were not aware of NIRS, could understand the principles of this technique and the application for the technique. And so one of the questions that I have for you is we hear a lot about consideration for continuous monitoring in patient admitted to neurointensive care unit. In particular, here in Oxford, we have an interest in continuous EEG. This is a project led by Dr. Prisco. I was wondering, can you please tell us what are the main differences between continuous EEG and NIRS? Because they are both valuable, they give different information, and they also have different specific time points when they might be useful for the clinicians.
Yes, so they're extremely valuable. Obviously, the EEG measure the electrical activity on these patients. So if it really depends on what is our clinical question, what is our goal for that patient, and the stages. So if the patient is heavily sedated at that time, the EEG might not give us a lot, except the tailor appropriately the level of sedation, while NIRS might help us to properly target the hemodynamic at that stage. If instead the electrical activity, the goal of our assessment at that stage, because obviously the patient might have epilepsy or might have impairment of electrical activity, we simply have to monitor the status of the brain at that time. Then the EEG will be the answer to that. So in many cases in medicine, these two weapons that we have really have to be used according to what is our goal at that time of the ICU.
For sure, because as you mentioned, in polytraumas, you might have more hemodynamical issues. In patients who are lagging behind and not waking up, you might have concerns about possible non-motor seizures, etc., etc. In your presentation, you were discussing different type of wavelengths, and the question for me as a attendee would have been, what would be the possible way forward, because some were working, some others were not. Have you thought about the type of wavelengths that we could apply?
Yeah, that's a very nice question. And at the moment, the supermajority of the NIRS devices that are out of the market are targeted to measure oxy and deoxyhemoglobin. So they mainly go to the 690, 670 nanometers to the 830, 810 nanometers for the deoxyhemoglobin. So you need two wavelengths with this kind of frame in order to monitor the true concentration of oxy and deoxyhemoglobin. They do not fit very well for the ICG assessment. Because the ICG is a very narrow window around 810 nanometers. So the future, what we are working on is trying to increase the number of wavelengths. You need more wavelengths in order to properly monitor either the brain saturation, as you should, and also the ICG passage. So we should not be limited to these two wavelengths and these very narrow frames, but we have also a wavelength or multiple wavelengths targeted exactly to monitor the ICG.
Yeah, what I hear is that the technique is still in its infancy, and there is a lot of potential that at the moment is not exploited to its fullest potential. And so from that point of view, I think that in over the next 5-10 years, we will see a lot more application for those like us who have an interest in traumatic brain injury. This might be a renaissance, really. Yeah.
Hopefully, fingers crossed.
Thank you, Mario. Thank you.
My pleasure, sir.
Nargisa, do you have any question?
No, I have question to Dr. Nikolaos. It was very interesting topic. And as I know, Dr. Nikolaos was working as a medical doctor at French Roland Garros. Maybe you could share your experience. And one question I would like to ask regarding the follow-up of the professional sport people. So how long do you follow up, whether they had in the history mild or severe traumatic brain injury, or they don't have. So they continuously are contacting with, I don't know, the high speed or difficult, situations when they have to climb or they have to skiing and doing a lot of rotation. So this is continuous pressure on brain. So how do you follow up the patients with the professional sport players, let's say? Thank you.
Thank you very much for the question and for the nice introduction that you did for me. The gold standard is to follow up them for 24 months. This is that also Dr. Caligaris from Italy, one of the pioneers of the sports medicine, proposed. The gold standard is to follow them for 24 months, 2 years time. When you have a professional athletes and you know what is the team, his sport, it's much more easy than when you have an amateur athlete to follow up, because the amateur athlete, perhaps you can lose him much more easier than a professional athlete. The gold standard is for 2 years. Now sometimes you can also do less, okay?
Okay, thank you. But is it difficult to manage professional sport people, because the sport is the part of their life, part of their job, and the money?
It is very difficult to manage.
Yeah, I'd like to give some input on that, Nick. I was a professional athlete. And mostly I'm Dr. John Bennett from Miami. I was trained as basically a regular doctor, but I worked my share of games and I was involved playing professionally. And it's very important. The doctor basically gets to know you on a team. He travels with the team, he gets to know you, and he can tell when a player's after a trauma to the head. He can tell what the player's like normally. And just from speaking with him and doing a quick neuro exam, they generally can tell whether to send them to the ER or not, or CT, because it's a big decision. These guys are highly paid, and teams want them to play if they can possibly play. Any comments on that, Nick?
I completely agree. I completely agree with you, John. When you are the medical officer of a team, you can give some question, the so-called Madlock's question from Australian guy Madlock, that she performed this question, also a very renowned sports physician, that you can understand how it is the mental connectivity, the mental activity, and the medical ability of the patients. Okay.
Okay, thank you.
Thank
so
you,
much.
Nick. There's a
Any
question
other
from
questions?
Ata.
There is a question.
Yeah, Ata Bhatti.
Thank you for all excellent presentations. So I like to ask Nicholas how he sees technology and artificial intelligence in future playing a role after sustaining a mild injury, for example, in a footballer. And there is a lot of work done in balance and motor activities, and you could monitor it, keeping a baseline and having some changes which could alarm the doctor who is looking after that patient to make a decision of allowing or just withdrawing from that game. Thank you.
Thank you very much. Thank you very much, dear Ata. We cannot able to see your face, but we appreciate your question. The machine learning and the technology, will help us in the near future, not in the near future, in the present. We can help us. There is a lot of work, but there is also, because we have to do with the return to play, and sometimes in compact sports like box, or like perhaps we can not do a perfect evaluation. The machine learning, it is very helpful, but under the sports physician and the neurosurgeon surveillance, where the medical surveillance is very important. Okay, but in the near future, in elements and questions like test balance, questions, evaluation, re-evaluation, it will be a very useful tool in our armamentarium in order to evaluate well our sports patients. It is we are now in the future, and we will see many good things. Okay.
Thank you.
Thank you very much. Thank you very much. Thank you very much.
Thank you, Nikolaos. I think with this question we can draw to an end of this grand round that we have started for 2024-2025. Nargisa, do you have any other outstanding question for our speakers, or can I draw to a closure?
No, I just want to say thank you so much, and thank you, Dr. Mario, that we restarted our grand rounds. And
yes, so grand rounds last year, they brought very positive results. We presented at the EANS in Sofia, and we are trying to do the very same for this academic year. So we can expect the next grand round to be organized possibly in the month of January, and will continue until the spring, and we'll see how far we can go. And I want to thank John, Dr. John Bennett, our host from Neurosurgical TV, and we're very happy to have you, John, as a partner in this initiative.
Well, Mario, it was very well organized by you and Nargisa. You went over every speaker. It was very well organized, and I appreciate your work, Mario, Hui Pham, and everyone that participated. So we look forward to our next webinar. Thank you very much, everybody.
Thank you, John. Thank you, everybody.
Thank you.
See you,
Bye-bye.
everyone. Thank you. Bye-bye.